Thank you all for joining. It's a pleasure to have you all, and I know it's the evening, so I'm extra appreciative of your time at the end of a long day um, to go over radiographic pulmonary anatomy and pathology. Um, just about me, Danny already kind of described it. Went to Auburn for my residency, did an imaging internship and externship, some ER, and went to Penn and UConn for my formal education. And I've been happy and excited to be with the Radimal community since 2022. It's been a great experience overall, and it's my favorite group to work with. So um, moving on from there, so today we're going to be talking about pulmonary radiography. We're going to talk about just recall some basics of normal radiography. Um, it's easy to forget the old basics. I've been out of school for a while. We're going to review normal anatomy. We're going to look at how we can obtain the best image possible, the GOAT images, as people call it these days. And then we're going to move on to pulmonary patterns, and we're going to have some case examples to kind of help supplement that and get an idea wrapped around of what all the jargon I'm talking about. So it's important to remember that radiographs are projection images. So they're shadows. They're shadows representing the anatomy that we're looking at. We're basically compressing 3D anatomy into 2D. And I like this image because one, I liked octopus is really cool, but also it really highlights how mischievous radiographs can be because obviously that's not a real hand. That's the octopus with all its tentacles touching each other, but creating the impression of a hand. And radiographs can do just that. They can create false impressions. And that's why at minimum we do orthogonal views or multiple views to try to recreate the 3D anatomy in our minds from the 2D images that we make. It's also important to remember that we have five major opacities. Now, that's going to be metal, bone, soft tissue, and fluid. They're the same opacity. And then fat, and then gas, in order of most attenuating to least attenuating, most white to most black. But also remember that there's shades of gray in between. So depending on the volume of tissue you have, if you have a humongous lipoma on the side of a dog's body wall, well, the center of that's going to be more soft tissue opaque because just so much volume of tissue that's going to start attenuating that X-ray beam as it goes through it. And the same thing with cats. Cats will sometimes put a decent amount of pericardial fat around their heart, and it can sometimes create the appearance of a big heart. So just be aware that there's shades of gray in between the five major opacities. Another thing I want to highlight is border effacement, which is sometimes forgotten. And that's basically when you have two structures that are the same opacity and they're touching. And when they're touching and they're the same opacity, you can no longer make them out from each other. You can't say, this is where this one structure ends and this is where one begins. You cannot distinguish their borders, and that's why it's called border effacement. And that has ramifications in terms of what you can see and what you can't see. And then superimposition is another term. That's an additive attenuation. So if you have a small bowel segment superimposed with the left kidney on a VD view, that small bowel segment is going to be more opaque than, say, a bowel segment next to it that's not superimposed with the left kidney. So it has an additive attenuation effect, a more white effect. Here we have a normal lateral radiograph. This is a left lateral view of a dog. And this is just to highlight where approximately the lung lobes are. And so with these highlights, we have the cranial lung lobes, the right middle, but in the left side, it's going to be the left cranial with two different segments superimposed with one another with the right. And then the right and caudal lung lobes. And then we have to remember that the accessory lung lobe kind of sits underneath that caudal vena cava in the center of the caudal thorax. So just remembering those basic areas of where they are can help you describe where you think a lesion is. It's very important. And then on the VD projection, we also have the same changes here. And remember that the left cranial lung lobe has two segments. They're subsegments. They share a main bronchus, and then it deviates and splits into two. Whereas there's a separate right cranial and a right middle. Again, we have our accessory down here. And it's also important to note that the right cranial lung lobe often protrudes into the medial aspect of the left cranial thorax, okay? And as we go back to this image here, you can kind of see the soft tissue line and that's the cranial-mediastinal reflection. And that'll be more or less conspicuous depending on the patient, how much fat they have in their mediastinum. But that's because of this protrusion. Okay. And that's important because I often get emails, texts, and addendum requests asking what this is. This is normal anatomy. This is the right cranial lung lobe pushing into the left hemithorax or in the left cranial thorax. And so it creates almost like this impression of like a bulla or some kind of pathologic lesion. But in actuality, it's because of that protrusion that it creates this impression. So that's true in both dogs and cats. Um, Going back to what normal anatomy is, it's important to realize that the lungs are going to be looking somewhat busy. It's very easy to overinterpret radiographs for pulmonary parenchyma at least, and that's because it's not just gas. It's a lot of gas for sure. It's the majority of gas, but there's also other things. There's vasculature, there's lymphatics, there's interstitium. So that's going to be your fibrous tissue, like your collagen and your elastin, that create kind of the makeup of the framework and the structure of the lung itself. Um, these are all soft tissue opaque, and so they're going to create opacities within the lung, and that's what we're seeing here. We're seeing vessels here, we're seeing bronchi. As you get closer to the hilar region, you're seeing some bronchi are mineralized, and so as dogs get older, especially middle-aged and older dogs, there's an increased prevalence of mineralization of those bronchial walls. You can also see it more commonly in dogs with endocrine disorders. So hypothyroidism is one, and Cushing's is another that commonly have bronchial wall mineralization. They're not clinically relevant. Um, so what we want to do is make sure that we're differentiating thin mineralized walls that are conspicuous but maintain thin margins versus bronchial wall thickening and pathology. Another thing to keep in mind is peak inspiration is difficult. I'm going to hammer on this a bit, but I understand that it is difficult. I've had to take radiographs. I understand it's problematic. It's the goal though, and that's where I'm going to keep trying to mention. I'm not being I'm not being callous or trying to say like you guys don't get it. You just need to get peak inspiration. I know it can be difficult, but just understand that it is the goal, and that's what we are trying to do to get the best diagnostic images possible. Another thing to consider is that lateral radiographs are more busy compared to VD and DV radiographs. And that's because we have superimposed anatomy, so that your lungs are superimposed with one another where they're not on the VD and DV. You have the mediastinum and structures within the mediastinum superimposed with the lungs. And so when you keep that in mind, you're going to have a busier pattern in the lungs. And if you're worried that that's a real thing, then what I encourage you to do and what I do is I look at the VD and the DV and I say, does this really persist? And if not, then I'm more able to explain it away as being of no clinical consequence. Another thing to remember is that the right caudal lung lobe has the most vessels, especially in the medial portion here next to this caudal vena cava, because it's one of the biggest lung lobes. And so it's going to need the most perfusion. And so it will look relatively busy over here in the medial aspect of the right caudal lung lobe. And so if you get an expiratory pattern, that can affect how we interpret things. That can be because the timing is off with the dog's respiration, could be panting, could be sedated or under anesthesia. If the dog's really obese or Pickwickian or has upper airway collapse, those are pathologic reasons for not being able to inspire and having an expiratory pattern. And this is just a zoom in of the same images, just showing the lateral view and how it's a little bit more busy than, say, on the VD projection. Another thing that we need to clarify are nodule fakeouts. And so the two most common nodule fakeouts are going to be pulmonary vessels and pulmonary osteomas, sometimes called benign pulmonary osseous metaplasia, or BPOMs. And so these are very well-defined structures. So on this side here, we're highlighting these pulmonary vessels. They're end-on, so they're coming towards the X-ray beam. And look how sharp and smoothly marginated they are. They're always round or slightly oval, depending on how exactly they're hitting against the beam. But they're mineral opaque, and they're very sharply marginated for something so small. I mean, these are in the 2 to 3 millimeter range diameter. And then If we look over here on this side, we've got an older dog with these little mineralizations. They're a little bit more irregular in shape. They still have a sharp margin. They're very opaque. They're very conspicuous to your eye. And so these are going to be osteomas. They're usually this small. They usually hang out in the periphery of the lungs. Occasionally, I should say rarely, you'll get ones that are quite large. And those have a more, kind of jarring look to them. But those are pretty rare. And so usually they're these small, a few millimeter sized. Here's a legend of 6 millimeters for comparison. So like they're between 1 and 3 most part. Now, the smallest pulmonary nodule of concern, whether it's metastatic neoplasia or a granuloma or an abscess or something like that, something pathologic that you're concerned about, the smallest lesion you're going to be able to see is 4 to 5 millimeters in diameter. And so when we use this legend, 6 millimeters, so if I just put my mouse over that 6 line, it's about 5 now. These are definitely too small and too conspicuous to be pulmonary nodules of concern. And compare that to, say, this dog here. It's a very zoomed in image of the cranioventral lung field. And these arrows are highlighting 4 pulmonary nodules. And these are nodules of metastatic neoplasia. Notice how they are much less conspicuous. Now that I've pointed them out, you can see them pretty clearly, but they don't have those sharp margins. They're not that opaque. They're pretty inconspicuous relative to what we just saw earlier. And these measure out between 6 and 7 millimeters. So they're not even the smallest that you see. So I want that to be the characteristic differences between when you're seeing a vessel or an osteoma versus a nodule of clinical concern. And then moving into what we want our radiographic standards to be, we really need 3-view radiographs. There's not really a good answer or excuse not to get 3 views. And the main reason for that is because when we're looking at lateral views, we're looking at the non-dependent lung. We're not looking really at the dependent lung much at all. And so if we look at this image here, what this is here, this is a slice of a CT scan of a dog in lateral recumbency. And so this is the recumbent side. This is the recumbent lung. And look how much more white or attenuating this lung is and how much smaller it is compared to, say, this one, this non-dependent lung, much more black, much more gas filled. And when we think about the diseases that we're concerned about with lungs, most diseases are increases in opacity, right, relative to normal gas-filled lung. And so if you have a lesion that is soft tissue opaque highlighted by gas, it's going to be pretty obvious to the eye relative to a lesion down here that's surrounded by a relatively opaque lung. It's going to be much harder to see that lesion. And so if we take, say, a horizontal X-ray beam radiograph of the thorax, this is that right here. So the X-ray beam is shooting through the sternum, the cassette's behind the dog, and the dog is in lateral recumbency like this. This is that atelectatic recumbent lung. Look how soft tissue opaque it is. The cardiac silhouette starts to compress on it too. This is the non-dependent lung. And again, try to find a nodule here compared to up here. And so now you start to see where, we're tying our hand around our behind our back, trying to figure out if there's any kind of pulmonary metastasis or any other pulmonary disease. There's many other diseases other than metastasis that require 3-view thoracic radiographs for complete evaluation. And so we want to make sure we're doing that every time. Rotated patients can be very problematic. You're often missing portions of the lung, and it makes the anatomy much more confusing and difficult to interpret. That's true not just of thoracic, but also abdominal images. We want to make sure that the thoracic limbs are pulled cranially, because the brachial soft tissues superimposed with that cranial lung field can be problematic, or maybe it's just a sternal lymph node that we can't say is real or not because that soft tissue is in the way. Whole body radiographs, they're problematic, and I know they're pretty ubiquitous and everyone does them, but I really wish that we didn't, because they create a lot of diagnostic problems and equivocalities, and I'm not able to do my job as effectively because of it. And part of that has to do with algorithms, and we'll talk about that in a little while. But really, you really need to separate your thoracic and abdominal images. In the age of digital radiography, it doesn't really cost you any more money to do a separate study. Moving on to expiratory radiographs, again, want to retake those just like rotated and other issues. Develop a quality control workflow. This is actually really important and something that I implemented when I was in small animal ER. And what I mean by that is you want to make sure that you are quality controlling the images. The clinician that orders the study is responsible for their diagnostic quality. And so if you're charging for a non-diagnostic study, that's not fair to the client, it's not fair to the patient, and ultimately it's up to you. And so what I would do in those cases is when I would order the study, I would order it to make sure that I'm going to be close by or near a computer so that I can immediately view the images while they're taking them or right after they take them. And then if I see a problem, like, okay, we need to take that right lateral view because it's expiratory or he's rotated or we cut off the caudal lung field or the cranial or the thoracic limbs are superimposed with the lungs, whatever the case may be. But that way you're making sure you're on top of the study, and you're getting it all done at once and not creating problems where, oh, now the dog's back with the client, we need to go get it again, or we put the dog back in the cage, we got to go back to the X-ray machine room and creating more problems for yourself. So creating a quality control workflow is really important. That's not just for radiographs too, for all of your diagnostic workups. Think about your workflow and how many steps you take to get from one side of the hospital to the other, and try to maximize that. Um, and then so a systemic approach to review, just like you do your physical exam, you do it the same way every time. That's what you want to do with your radiographs as well. I kind of keep hammering on this, that peak inspiration is the goal. And so when we're looking at this view here, this right lateral view, these lungs are relatively expiratory. They're not fully expiratory, but there's definitely a haziness here that we lose here where there's better inspiration. The diaphragm's more caudally positioned, more flat. So it's easier to see a lesion here than here. And this is a mild example of that. A more extreme example is when we have a dog under anesthesia or heavy sedation, but in this case, anesthesia, the dog's intubated, and we have pretty much a completely expiratory VD radiograph. And this is a dog that was having a dental, and towards the end of the procedure, the dog started oxygenating poorly. And so they took these radiographs, and I said, hey, I called them, I said, hey, I can't see really anything here. I don't know what's pathology versus what's atelectasis because the lungs are pretty much alveolar throughout. There's more unstructured interstitial over here in the left caudal lung lobe, but most everything else is alveolar. I can't tell you if this is pathologic or not. Can you retake the study and apply positive pressure ventilation? So what they did is they got the reservoir bag and they compressed it to get to around 25 to 30 millimeters of mercury, and they briefly held it there for each radiographic image, right? And that way, you now have a much better aerated lung field. I can see the lungs much better now. And when we compare the two, what I do see is I see there's a persistent alveolar pattern in this right cranial lung lobe. There's an air bronchogram here. There's a smaller alveolar pattern in the right middle lung lobe. So we have a case of aspiration pneumonia that I could never possibly in a million years diagnose on this view. This right here is just the caudal mediastinal reflection. The dog is a little overweight and likes to deposit fat in the mediastinum. So sometimes you'll see that thickening there, but it's not pathologic. And then moving on, I briefly mentioned rotated patients. And so, you want these ribs to be superimposed with one another. You don't want them to be so far apart from one another. All of this lung up here is superimposed with the ribs and the vertebral bodies and the soft tissues. This is not evaluable. I can't evaluate this lung at all. Also, want to make sure that those thoracic limbs are pulled cranially. So this is a study that I would say you should probably retake. I mentioned algorithms and whole body radiographs and why algorithms matter. This is the same dog taken at the same time. On the left hand, we have a thoracic radiograph with a thoracic preset algorithm. So when you're picking, abdomen, thorax, musculoskeletal in the X-ray machine computer, you're choosing the algorithm preset. And these companies that design these, they design them specifically so that for abdominal radiographs, there's inherently increased contrast. So the machine and the software interprets all those pixels differently than the thorax in order to enhance contrast, because abdominal contrast is inherently lower than the thorax where there's so much gas. And there's really no gas in the abdomen except for within the GI tract. The rest is just fat and soft tissue. So there's inherently less contrast. But look what it does to the lungs. We have lungs here, a decent amount of lungs included here on the abdominal thorax, on the abdominal study with an abdominal algorithm, and compared to the thorax. Look how much more busy the lungs look. Look how much more bronchial the lungs look. It's very easy to overinterpret this. And so this is just one other reason why, whole body radiographs and choosing the right algorithm and preset is important. This is the same thing, just the opposite side, left lateral, thorax with a thoracic preset, abdominal with an abdominal preset. Again, very busy lungs compared to the thoracic images. Again, thoracic preset, abdominal preset. Okay. The other thing too with whole body radiographs is, we need peak inspiration for the thorax, but we want peak expiration for the abdomen. And so that's another area where you have opposing needs. This is another suboptimal radiograph in which the patient's moderately rotated. There's way too much abdomen included, and the thorax is not centered on, or sorry, the X-ray beam is not centered on the thorax. This is an older Yorkshire Terrier presenting for coughing, not too surprising. And what you may notice is that the lungs are very, very poorly inflated, and it has a general haziness, a very increased unstructured interstitial opacity, you could call it. And because the lungs are so poorly inflated and there's so much contact between the diaphragm and the cardiac silhouette, I can't tell you if this is pathologic or not. I can't tell you if there's pathology hidden in here. I can't tell you anything really about the lung quality of this study. A lot of people worried about tracheal collapse, given it's a Yorkie. Well, this trachea looks pretty good. There is a little soft tissue band superimposed with like the dorsal third of the trachea, but you can see the dorsal margin above it. So that's not tracheal collapse. That's either going to be a superimposed esophagus or that's going to be a redundant dorsal tracheal membrane. That's not tracheal collapse. What this dog does have is carinal and mainstem bronchial collapse. These are completely collapsed down here. And that's another form of dynamic lower airway collapse that you can get with usually small breed dogs like the Yorkshire or poodles, mini poodles, and things like that, Maltese. And so that's going to in this case, this is the reason for this very poor pulmonary inflation is the dog cannot open those lower airways up to inflate properly. Now on the VD view, the dog is able to aerate to a moderate degree. It's not perfect, but it's better. There's still decent contact between the diaphragm and the heart, but it's definitely better. And I can definitely evaluate the lungs much better. And I can tell there's no pathology here of concern. So persistence of pathology, looking for things dynamic like that, and making sure you're interpreting these types of expiratory patterns with extreme caution and look for persistence. Because if it looks normal on here, then you could be more confident that this is just all artifactual from relative atelectasis. So moving into our pulmonary patterns, we've talked about normal anatomy and kind of age acceptable changes, and now we're going to go into some of the pathologic states. So the alveolar pattern, this is basically an accumulation of something, whether it's a cellular buildup, fluid, or tissue, or fibrosis in some cases, occupying the normal airspace. So the alveoli and the bronchioli that are responsible for gas exchange. The technical definition is a soft tissue opacity border effacing with the pulmonary vessels. So here we have a zoomed in area of the cranial lung field of a dog. And these arrows are highlighting the lobar bronchus of that lung lobe. And just above it, we have this vessel here, this soft tissue opaque vessel. That's your artery, that's your pulmonary lobar artery. And just ventral to the bronchus is the vein. So you have your artery, bronchus, vein. This is your bronchovascular bundle. And notice how we can see just outside of each vessel because it's surrounded by air. But if it's surrounded by soft tissue from, say, an alveolar pattern, then guess what? We have soft tissue and soft tissue in contact with one another. We're going to get border effacement. And then we're no longer going to be able to see those vessels. We may see the air bronchogram, which is the gas-filled bronchus, contrasting with the alveolar pattern, but we're no longer seeing those vessels. So soft tissue border effacement of the pulmonary vessels is the technical definition of an alveolar pattern. What really is just soft tissue opacification of the lungs. You don't need an air bronchogram to call it alveolar, but if you see one, then you know you have it. So it's not necessary, but if you see it, then you know you have it. Alveolar patterns are often acute or subacute in terms of disease processes. That's not 100% of the case, but it's just more typical. Okay, it's the general common guideline, not a rule, not a law. And it's important to remember when you're looking at any alveolar pattern or any pulmonary pattern, you want to look at the distribution. The distribution is going to help decide on your differential set. It's as important as the pattern itself. It's not just about the pattern, it's about where the pattern is. And again, knowing where your lung lobes are, knowing your anatomy will help you with that. This is just a schematic to kind of help conceptualize what we're talking about here. So on the normal side of the lung here, we have a lobar bronchus, we have an artery outside of it, we have a vein, and that's your bronchovascular bundle. We have these hexagon alveoli that are gas-filled and dark in color, okay? In the pathologic side, we have this soft tissue whiteout occluding the normal airspace. And what that does is it border effaces with those pulmonary vessels on each side of the bronchus and then highlights the bronchus if it's gas filled to create an air bronchogram. It also border effaces with anything that's the same opacity touching it. So the cardiac silhouette in this case is soft tissue opaque. So is this alveolar pattern. They're touching. Now we have border effacement. Okay. So for alveolar patterns, I like this kind of background because you can't really see the skiers and where the line is of the mountain from the background from the sky because it's all white out, and that's kind of what alveolar patterns do is they kind of white things out and make things harder to distinguish from one another. And so we have up here we have a dog with a pretty severe alveolar pattern that's cranioventral and ventral. You can see a nice air bronchogram here, more air bronchograms here, and more here. As you get a little bit more dorsally, it starts to become more patchy and kind of granular, unstructured interstitial as you move, in the dorsal direction. It goes a little bit more that way, and that's typical of pneumonia. And so this dog has pneumonia in this case. Another dog here has a focal alveolar pattern just superimposed with the cardiac silhouette in the right middle lung lobe. This is the most often missed by clinicians because they know subconsciously in their mind that the cardiac silhouette is soft tissue opaque. And so they're not especially evaluating the lung superimposed with the heart as they do over here or more caudodorsally. So we have normal lung out here, and then we have this increased opacity that's See, it's greater opacity here than here, right? These two areas are different because you have some superimposition of this affected alveolar pattern with the heart, and then you have these air bronchograms. So make sure you're looking at the cardiac silhouette and the lungs overlying it because this is often missed when it's just there. In terms of differentials and most common versus least common, this is kind of the hierarchy. Pneumonia is probably the most common. Atelectasis is very common too, whether it's from incidental physiologic causes like sedation or anesthesia, or bronchial plugging from either mucus plugging or like a tumor or a nodule can obstruct an airway. And then pulmonary edema, whether it's cardiogenic or non-cardiogenic, so you're going to be looking at things like, how big is the heart? What do the vessels look like to help differentiate things? On auscultation, do you hear a murmur? These types of things. As we get into less common causes, we get into things like hemorrhage, which can be from, say, a coagulopathy or pulmonary contusions from automotive trauma. Neoplasia, often round cell will create an alveolar pattern. People forget that round cell can also do nodules and masses. So if you have a distinct nodule or mass in the lungs, that doesn't rule out round cell. It doesn't have to be like a soft tissue sarcoma, MET, or carcinoma. It can be round cell as well. But round cell often will create alveolar infiltrates and unstructured interstitial infiltrates as well. Infarcts, some people lump them in with hemorrhage, although it's a separate pathophysiology from, like I say, coagulopathy and pulmonary contusions. This is an actual obstruction of the vessel. And then we get into zebras like lung lobe torsion, and then we're getting past the point of helpfulness at that point. So this is the same dog, the same image, left to right. Just to highlight on the right-hand side, the air bronchogram and the alveolar infiltrates. Some dogs with pneumonia will have a more caudoventral distribution in addition to cranioventral. So don't rule out alveolar from pneumonia just because of that. This is a dog with severe cardiomegaly. You can see here that the trachea is pretty dorsally deviated with the carina. We have a large soft tissue bulge in the region of the left atrium, which corresponds with this double opacity over here. We have severe widening of the cardiac silhouette on the VD projection. And we have this alveolar infiltrate that's bilateral, more severe on the right, which is typical with left congestive heart failure. We have very well-defined air bronchograms on both sides. Out to the periphery, it's more normal lung. And on the lateral view, again, it's perihilar, it's caudodorsal. It's also caudoventral. So you can get caudoventral infiltrates from left congestive heart failure. It's not just purely caudodorsal. And this is just the opposite view, showing again, huge heart. You can see this chunky vein here that helps support left congestive heart failure. We have the infiltrate. We have the infiltrate down here as well. This is another case of pneumonia in which we have a very well-defined alveolar pattern with a beautiful air bronchogram that you can see very clearly. This is I think I said pneumonia already. So that's pretty much for alveolar. Interstitial is a complementary pattern or infiltrate, and it represents cells, fluid, or fibrosis within the interstitium. And the interstitium, like I said, is that lattice network in between the alveoli and the bronchi and the bronchioli that basically give it form and structure and elasticity. It holds the pulmonary vessels and the lymphatics. Because the anatomy is so intimately associated with each other, it can be very difficult to distinguish an interstitial from an alveolar. The main difference is technically you can still see pulmonary vessels with an unstructured interstitial pattern. And so they're going to be less well defined. They're going to be more obscured from visibility, but you can still tease them out. And that's the technical separation between an unstructured interstitial and an alveolar. It's important to know, though, that a disease can have both interstitial and alveolar patterns or transition from one to the other at any point, depending on the disease process and how it's progressing or regressing. For instance, that dog with heart failure had an alveolar pattern. 24 hours later, if we gave it diuretics and pemobendin and rechecked radiographs, a lot of that would clear up and you would still see some unstructured interstitial changes because some of that pulmonary edema persists, just not nearly as much. And so those are the kind of the caveats we have to keep in mind, and that they're kind of complementary patterns. They kind of mean the same thing, but to less degree of severity in some cases. And so looking back at the schematic, we have these hexagon alveoli, and the outer areas in between them is the interstitium, right? And so we're going back to, we have our lobar bronchus, we have our artery, we have our vein, we have our bronchovascular bundle. And then in the pathologic state, we're going to have cells or fluid or fibrosis occupying mainly the interstitium. Now, in reality, some of the alveoli are filled up with this stuff too. What we're doing here is we're kind of oversimplifying things. We're putting things into tight boxes for our conceptual nature, but in reality, there's going to be some overlap. But for the most part, let's say we're saying it's interstitial, so it's in between the alveoli. We can still see those vessels, right? But they're not nearly as well defined. So that's the distinction between an alveolar and interstitial. A lot of people describe interstitial as a generalized fog. And so that's kind of what this background is here to represent. Some people use unstructured interstitial and interstitial interchangeably. Just keep that in mind. And that the differentials for alveolar are the same as interstitial. The caveats to that are these three are more commonly associated with interstitial rather than alveolar. They can still become alveolar, but things like pulmonary fibrosis, such as like your West Highland Terriers with idiopathic fibrosis, or dogs with chronic bronchitis that develop secondary fibrosis, will have more of an unstructured interstitial pattern. Viral pneumonia, more commonly but not exclusively, will cause an interstitial pattern. And pneumonitis, so inflammation of the pneumocytes and the lungs. It can be from an inhalant, like a caustic inhalant irritant, or uremia can do it. This is the same picture, same radiograph on both sides, and just kind of circling and highlighting. Notice how grayed out everything is in between those vessels and bronchi. The vessels and bronchi are not nearly as isolating and distinguishable for your eyes. And in between them, it's just a hazy increased opacity, right? I can still make these vessels out. They're just not nearly as well defined. And so this is a dog that has a pretty significant unstructured interstitial pattern. It's fairly diffuse. You can see some of it right here, but it's definitely more severe caudodorsally, right? Um, just increased haziness throughout. And you can see it orthogonally as well. We're having that persistence of pathology here. And oh, let me go back for just 1 second. There's this convex soft tissue opacity here I don't love. That is in the spot of the sternal lymph node. And on the opposite lateral view, it persists. It's even more conspicuous on this view, despite the thoracic limb being somewhat caudal in position. And we still have that infiltrate, that interstitial pattern. So when I'm connecting the dots here with this infiltrate and the sternal lymph node, your mind is going to want to go to malignant neoplasia, typically a round cell. So this dog had pulmonary lymphoma with multicentric involvement that included at least the sternal lymph node. It's another dog that has a mixed pattern in this case. The predominant pattern throughout most of the lungs is unstructured interstitial. However, as we move caudodorsally, it becomes more consolidated to an alveolar pattern. And that persists on both views here. It's bilaterally symmetrical. If we look at the other opposite lateral view, it has a persistence there as well. This is a case, now your differential sets can vary here, and there's a number of differentials you'd want to have. Things like pulmonary lymphoma would still be on the list, or malignant neoplasia such as lymphoma or round cell. Hemorrhage can definitely do this. PTEs can do this, a subset of hemorrhage. Non-cardiogenic pulmonary edema, considering the caudodorsal distribution, you'd have to keep in mind. In this case, the dog was severely azotemic. And so this is a case of bad uremic pneumonitis. And you wouldn't be able to call that out based on the radiographs alone. Like I said, all those other differentials are very plausible as well. But when you compare it with, the clinical history, your exam findings, your lab work findings, now we can kind of piece it together. Moving on from unstructured interstitial is structured interstitial, aka nodules and masses. It's just a word mouth to say structured interstitial, and so it's not as commonly employed in dialogue between people anymore. And you'll see it mostly in the literature. Some people may use that term when you're talking to them, but most people just say nodules and masses, and that's why unstructured interstitial is just often called interstitial in general without the unstructured qualifier. So these are discrete nodules and lesions. They're fairly well defined compared to the more amorphous looking interstitial and alveolar infiltrates. Um, there's not too many things that it can do in terms of what it is. So neoplasia is going to be, a pretty common and concerning lesion. A granuloma or an abscess are your other differentials to keep in mind. Occasionally you'll get fluid-filled cysts or pneumatoceles, which are like usually traumatic lesions or like a ruptured bulla that become filled with hemorrhage or inflammatory fluid or transudate or hematomas, that sort of thing. So this is a fairly straightforward case of a dog with a large solitary pulmonary mass. It's ovoid in shape. It's located in the left caudal lung lobe. It's got very sharp, well-defined margins. When we look at the opposite lateral view, this is the left lateral view, notice that the mass kind of becomes more dorsal in position. That's very typical of a mass when it's on the recumbent side, or a nodule. It doesn't have to be a mass. But in this case, we obviously know it's the left lung field based on the VD view. But if it's a smaller lesion and you can't clearly see it on the VD view, on the lateral view where it goes more dorsal in position, that's usually the side it's on, that recumbent side. This dog also has structured lesions. These are not well visualized or not nearly as clearly visualized as in the prior study. So if we look very, very closely in the craniodorsal lung field, you'll start to see there's an increased opacification. There's some margins you can kind of start to delineate now that I'm highlighting them on the other view. And then if we look more caudal ventrally in the same view, you're going to see another lesion, right? And again, not the sharpest margins, but now that you see it, it's kind of hard to forget it. On the opposite view, you can see that cranial dorsal lung lesion much more clearly. The margins are much better defined, okay? And we can see some more details like how there's gas in the center. So it's a cavitated lesion. It's a gas, a lot of lesions in the lungs, nodules and masses can become cavitated. And notice that the other lesion, the caudal-ventral lesion, is totally missing. We don't see it at all. So based on that, because I can see this craniodorsal lesion best on the left lateral view, I'm going to guess that it's going to be in the right lung lobe, the right cranial lung lobe in this case. And the opposite's true of the other. I don't see the lesion on the left lateral view caudal-ventrally, so I'm guessing that's going to be the left lung lobe, the left caudal lung lobe. And lo and behold, we have the mass up there in the right cranial and the mass down there in the left caudal. Okay, so that's where that persistence of pathology, using all your reviews, can really provide all the evidence we need to make a solid conclusion without any equivocality. This is a case of a thin-walled structure in the lung. It's uniformly thin, it's soft tissue opaque, and it's completely filled with gas. So this is a bulla. It's a benign lesion. You'll see it a lot in your huskies and malamutes and things like that, Siberian breeds, and those are benign. This middle lesion is much more complex, irregular in shape. It's got a much more variably thickened wall, okay? And the gas cavitations are much more irregular. This is a pulmonary mass in a cat, and so neoplasia would be the priority here. You can't rule out a granuloma or an abscess, so you can get fungal disease, or you can get, parasitism or a sterile granuloma. But more often as they get older and just in terms of commonality, neoplasia takes the top priority usually. And this is a similar lesion in a dog in the cranial lung field. Again, very variably thickened walls, irregular gas cavitations, neoplasia, granuloma, abscess are going to be prioritized, unlikely things like a pneumatocele. Moving on to bronchial. Bronchial is conceptually the easiest to understand, right? So we're going to have some type of inflammation, edema, maybe some fibrosis. There's an insult happening to the airways, and what the response to that is thickening of those walls and inflammation and edema. Okay. Again, we want to differentiate that from bronchial wall mineralization, these very thin, well-defined, very conspicuous bronchial walls from the pathology. Okay. Another thing to caveat, which makes it difficult to understand from the conceptual standpoint, which is easy from the practice of interpreting and calling things truly bronchial in a pathologic sense, is the realization that one, lungs look busy normally. Two, we have the bronchial wall mineralization in older dogs, and those with endocrine disorders. And three, you can have mild bronchitis with no radiographic features of bronchitis. So the reality is the sensitivity of radiographs for mild bronchial disease is not great. And so you will definitely find cases where they have bronchitis, you do the BAL, you do the transtracheal wash, you treat them empirically, and they get better. Because they do have the disease, it's just there's a certain cutoff where you're not going to see it versus you are going to see it. So just keep that in mind. And that's what makes it a little bit more tricky compared to the conceptual understanding of bronchial disease versus, true bronchitis. Dogs often have an interstitial component related to their bronchitis, and that makes them a little more tricky because you want to be able to identify the predominant pattern. There's the bronchial, and then there's the unstructured interstitial. We want to make sure we're saying, okay, I think it's mainly bronchial, and then there's a mild or unstructured interstitial component to it. So I try to tier my mixed patterns, so I'm documenting what I consider to be the worst offender or the worst pathologic portion of it. Cats are a little easier. They typically have a more pure bronchial pattern without all those interstitial changes. So they're a little bit easier in that regard from a diagnostic standpoint. In terms of our differential list, they're pretty easy and much more confined, I would say. So you have your infectious, usually we're talking bacterial or parasitic, uncommonly viral by itself unless mixed with a bacterial agent. You're inflammatory, so that's things like lymphoplasmacytic bronchitis. You think about bulldogs and things like that. Allergic, you think about an eosinophilic component. That's your feline asthma primarily. Inhaled irritants, So that can be something more acute, like a smoke inhalation fire issue. Home's on fire and you rescue the cat or dog, or it could be more chronic, prolonged exposure. Your barn cats with all the hay and all the particulates in the air, or a smoking household will definitely do it too. And so what we're looking for in this is just excessive visibility of bronchial tram lines and donuts and wall thickening, and sometimes that parabronchial cuffing that we talked about. And so in this case, you could see these donuts, they have pretty thick walls. We could see some tram lines, which are kind of running across the image, whereas the end-on bronchi are creating those donuts, okay? This is a cat that has a pretty nice bronchial pattern. You can see these donuts, they're pretty well defined. You can see the tram lines extending to the donuts, which is kind of cool. There's a great tram line here. That wall is way too thick. So this is unequivocal bronchial disease. Your tears are going to be, feline asthma versus infectious, it's like mycoplasma and things like that, or chronic inhaled irritants, like I said, smoking household, particulates in the air. Many cats with chronic bronchitis, will develop atelectasis of that right middle lung lobe. So we have an alveolar pattern there. It's important to remind yourself that if you have bronchial disease and you see that, it's most likely atelectasis and collapse of that lung lobe rather than pneumonia. So that exudate and that mucus buildup from the bronchitis will occlude the right middle lung lobe, lobar bronchus, and over time, gas will diffuse out of the lung. It'll become completely collapsed. So that's very typical. So it's fine if you want to put pneumonia on your differential list for a case like this, but in cats, your primary differential should probably be atelectasis from bronchial plugging. This is a dog that has a very, very severe bronchial pattern. And in this case, this dog has very severe cotton ball-like unstructured interstitial parabronchial cuffing. So that's what we were talking about earlier. And we can see it almost looks like nodules. It almost looks like there's nodules everywhere. But if you look closely, there's always a small little bronchus in the center or right next to it. So this is a severe case of bronchial disease. This is actually a case of eosinophilic bronchopneumonopathy, which is an immune-mediated disease in younger and middle-aged dogs with females overrepresented, and you treat it with immunosuppressives. And so sometimes they'll have a peripheral eosinophilia. Many times they don't, and you need to do airway washing to get a diagnosis. But they usually respond very, very well to it. So. And then this is a case of a dog with bronchitis. Brachycephalic breeds like your Frenchies and your Bulldogs often have a more conspicuous bronchial component. Whether or not it's clinically relevant is difficult to say. And you also have the competing aspect of, well, they also have brachycephalic airway syndrome. So is the coughing and respiratory issue related to that, or these lower airway changes? And these are really tricky cases. And so my first rule of thought is, make sure the upper airway is okay, and then look to the lower airway, unless you have something very obvious that points you to the lower airway first with these guys. The last one is the vascular pattern. And again, this isn't a ubiquitously used term. It's definitely used in older textbooks. I don't hear it used much among colleagues, but it's basically just an enlargement, distension, and increased visibility of the pulmonary vessels. It can be arteries and veins, such as with left congestive heart failure. It can be veins only with left congestive heart failure. It can be arteries only with pulmonary hypertension, or cats with left congestive heart failure. They're primarily arterial rather than venous enlargement. Asymmetric you can get with like shunting of the blood. If, say, the lungs on one side are completely collapsed, well, the blood's going to be shunted to the remaining lung lobes, and it's the same volume being pumped by the heart, and so the lungs have to adapt to that. Or if there's an infarct in a major lung lobe, and again, that blood has to be shunted to the other vessels, and then you get into weird zebras like arteriovenous malformations, which we're not going to get into. But this is a dog. It's a larger breed dog, like a Doberman, and we have a tall cardiac silhouette with a soft tissue bulge. We have a pretty severe mixed interstitial and alveolar infiltrate. It's pretty severe caudally, not necessarily caudodorsal, but kind of mid-caudally. And the cart isn't humongous, but it is big for a large breed dog. And so when you get those smaller breed dogs with the mitral valve disease, they usually get these humongous hearts. With larger breed dogs with DCM, it's not as pronounced. And so just keep that in mind. What we can see here is we can make out, despite this infiltrate, we can make out this artery here. We can make out the bronchus, and then we can make out the vein here. And this vein is very chunky compared to that artery. And so this is just highlighting those two, and that supports your left congestive heart failure diagnosis. This is a cat with cardiomegaly, heart's too tall, heart's too wide. The artery is quite large. Again, the arteries are primarily enlarged compared to the veins. This artery is quite big. It's a little bit bigger than the vein, and you can kind of make a sliver of a lucency, which is where the bronchus is. These are too big relative to the fourth rib set, way too big. It should be about the same size or smaller than in width. And also you can see these like little thin lines extending off from these lobar vessels. And so these are your tertiary vessels. You shouldn't see those. So when you see tertiary vessels in a cat, you know you have vascular distension. And so you have these big vessels here as well, more vessels out here. The opposite lateral view is same thing, very chunky vessels. You could see tertiary vessels. You have this infiltrate that's ventral and kind of mid-caudal. That's the typical distribution for cats with left congestive heart failure. Also some pleural fissure lines because cats with left heart failure get a little bit of pleural effusion as well. Very unique, unlike dogs. And then the last case is just going to be showing that at the 1 to 2 o'clock position, big soft tissue bulge at the cardiac silhouette of this dog on the VD view. This is the main pulmonary artery. It then splits up to the main stem, left and right pulmonary arteries. Humongous, absolutely huge. Harder to see in the periphery on this VD view. If you want to see them better, you get a DV view, but you can see on the lateral views here, very tortuous and still very enlarged out in the periphery. And so you get a little bit of aneurysmal dilation, tortuosity. It's a classic heartworm case with pulmonary hypertension in which the arteries are enlarged. Just some final thoughts because we're running out of time, but you just want to make sure you set yourself up for success with quality images. We can't, see things in a video format with radiographs, and we're only capturing at one point in time. So we want to get the most diagnostic value out of it. Look for that lesion persistence. Look at multiple views. Determine the primary pattern, and then look at ancillary patterns that may be included. That'll help with your differential set. And then, remember the distribution is equally as important as the pattern itself. That'll help you with your differential tier list. It's important to remember that you can use serial radiography either to confirm or rule out pathology or to monitor its progression or regression. So, make sure you have, if you're able to, look for a reduced cost fee for the radiographs on recheck within 2 weeks for the same issue. That can help provide some financial relief, but also allow you to perform really excellent medicine and get you more information on that patient and how they're doing, as long as financially it makes sense. And then seek consultation. With Radimal, we have a really busy Slack channel where we constantly talk about cases. We get second opinions with one another, the radiologists, because sometimes I see a case, I'm like, this is confusing, and I just want secondary input. And so whether that's with a mentor or a colleague at your practice or a specialist in your network or a radiologist or anyone else that you think you can get valuable information from regarding a case, I definitely implore you to do it. I learn a lot all the time when I do that, and it really makes my job enjoyable. These are some resources that you can look into. The case of the week is an emailed case of interesting radiographic study, a ton of backlog of cases that Allison Zwingenberger has created. She's not active on the website anymore, but it's still a huge number of cases that are excellent. Thrall's textbooks, especially the Atlas with the anatomical variants, excellent. The BSAVA manuals, specifically the thoracic and the musculoskeletal, are fantastic. Abdominal is okay. I don't love it as much, but it's still pretty good. And then, so that's it. Basically, just at the nick of time. Sorry I didn't have too much time to do questions, but I will stay a little bit later if anyone does have questions. With Radimal, I'm one of the primary readers there. We do offer 3 free reports if you want to sign up. And yeah, so happy to take any questions from anyone.